Welcome all to the today's session. Today we are going to have discussion on talk articles from the maternal medicine module, and these talk articles are important from SBA point of view. So we start with our quote, Master MRCOG with concept-oriented clarity. Today's talk article for discussion is a solid organ transplantation pregnancy. Nowadays, incidence of the patients who have become pregnant and already on organ transplant is on higher side, and in UK around 50 to 60 pregnancies per year they come across this situation that they have got some or the other transplant. And the most common transplant which you come across in pregnancy is the renal transplant. Okay, so what are the risk in these patients? They are a high risk for the pre-eclampsia, FGR, and preterm birth. So these are the risk in these particular patients. For these patients, vaginal delivery is not contraindicated. That is one of the factors which you should remember. And these patients require multidisciplinary care. Okay, especially in part 3, when you will have such kind of station, you need to utter this word multidisciplinary treatment or multidisciplinary management. Okay, the most important these patients is the pre-pregnancy counseling. Okay, so this is essential for all transplant recipients. That will reduce the maternal morbidity and mortality, and it will also provide them effective contraception. So till they make their decision to become pregnant or their counseling is completed. Okay, so what is the timing, ideal time when they should conceive? The pregnancy should be avoided within 1 year after the transplant, because in this time, in the first year after the transplant, generally the immunosuppression doses, drug doses are on higher side, and there is a chance of acute rejection around 10 to 15%. After 1 year, generally it is safe. The graft function has also become stable. Okay, so how to assess the risk before the pregnancy? So it depends upon the graft function, hypertension, proteinuria. So these are the factors which will indicate whether there is a risk or not. So good graft function, patients will have normal EGFR. There is no clear increased risk of graft rejection and graft deterioration because of pregnancy. Okay, so additional factors are, it may be underlying disease such as diabetic nephropathy. It may be because of diabetic retinopathy, neuropathy, etc. They may be associated. Then SLE, antibody profile will also affect the risk which is associated with the pregnancy. Okay, now let's talk about the medications which these patients have. Generally, the medications required are the mycophenolate mofetil, AC inhibitors, ARBs, and statins. Now, these are the drugs which are not safe in the pregnancy. So, mycophenolate mofetil needs to be stopped. It is teratogenic. The drug which is safe is azathioprine. So, if the patient is on mycophenolate mofetil, the patient is to be switched to the azathioprine, and it is safe alternatives. Okay, so this also you can remember from SBA point of view. Other drugs like AC inhibitors, ARBs, these are teratogenic. Even statins are contraindicated, and we need to stop these drugs. Okay, so important points are azathioprine is a safe in pregnancy. Ensure graft stability before conception. Washout period for mycophenolate is minimum 3 months before conception. During this time, the patient should be on folic acid at least 400 microgram per day. Okay, so certain special scenario as far as renal transplant is concerned, because proteinuric patients generally they become stable on AC inhibitors or ARBs. Okay, so these patients who are on ACE or ARBs, these patients, uh, the drug can be continued till the pregnancy test becomes positive. After that, you need to stop. Okay, so mycophenolate you will stop 3 months prior minimum, while ARBs and AC inhibitors can be continued till the urine pregnancy test becomes positive. Okay, now what is the effect of renal transplant on pregnancy? The outcome will depend upon the pregnancy outcome will depend upon the renal function, hypertension, and proteinuria. In general, principle is that worse the renal function, worse is the pregnancy outcome. Okay, so and what is the effect of pregnancy on renal transplant? Generally, pregnancy does not have much effect on the renal transplant. There is no significant difference in pregnant and non-pregnant recipients. Okay, those who become pregnant, they generally do not have different outcome as far as renal transplant is concerned. The 5-year graft survival is around 89% in pregnant and 85% in controls, almost same. So long-term outcomes are reassuring. So pregnancy per se does not have much effect on the graft. Okay, so acute rejection chances are 2 to 4%. In UK, it is less than 2% data shows acute rejection, and most of these patients will show a rise in the creatinine. And this rise in the creatinine, you need to differentiate it from pre-eclampsia, because if it is due to the pre-eclampsia, then it is not a rejection. Okay, so careful monitoring and differentiation from the pre-eclampsia is required, because this creatinine rise may put us in dilemma whether it is pre-eclampsia or whether it is a graft rejection. So when to suspect rejection? If the creatinine is increased more than 20%, in that particular case, we need to think about it, but we have to differentiate it from the pre-eclampsia. Okay, so what is the diagnosis of graft rejection? It is by the renal graft biopsy. Okay, it is better than the kidney biopsy as such. Then slightly increase bleeding risk, but it is theoretical. Management of rejection, how this rejection is to be managed? By use of corticosteroids, and the drugs which are used are the tacrolimus and the cyclosporine. Okay, so biological agents in pregnancy, we will have a separate discussion in today's talk also. They do not have proven teratogenicity, but there is an active placental transfer and neonatal drug levels are increased. And that is why generally these biological agents we stop in the latter part of the pregnancy when the placental transfer is increased. So what are the neonatal implications? So these patients who are on biological agents, for neonates, avoid live vaccines for the first 6 months. Okay, BCG, then rotavirus, MMR, varicella, oral polio, yellow fever, typhoid, liver influenza, etc. These patients, these vaccines are to be avoided. Okay, so avoid pregnancy less than 1 year after the transplant. Mycophenolate is teratogenic, so switch to azathioprine. AC inhibitors and ARBs must be stopped once the urine pregnancy test becomes positive. Best predictor of outcome is the pre-pregnancy renal function. Most increase in serum creatinine in pregnancy is because of pre-eclampsia and not the rejection. Rejection rate is very less than 2% in the UK. And biological agents, they are live vaccines are to be avoided in the neonates if the mother is on biological agents. At least for 6 months, the live vaccine is to be avoided. So how the this risk is stratified? So if the patient has got decreased GFR and increased creatinine level, there are likely chances that the pregnancy will have adverse outcomes. Then hypertension, proteinuria. The presence of hypertension may indicate that the preeclampsia chances of preeclampsia are high, FGR chances are high. Then if it is a proteinuria, then there is a diagnostic difficulty. Also, this increases the VTE risk in these patients. Okay. So also underlying disease like SLE, diabetes, that will also influence the maternal and fetal outcome. Medications we have discussed, azathioprine is safe, then tacrolimus is safe, cyclosporine, prednisolone, LMWH, that can be continued. Okay. While teratogenic agents which needs to be stopped are mycophenolate, mofetil, AC inhibitors, ARBs, statins, warfarin. Okay. This mycophenolate, you need to switch to azathioprine at least 3 months prior. Tacrolimus, AC inhibitors, you will stop or switch early. ARBs, you will stop. Statins, you will stop. And warfarin is to be avoided in early pregnancy. So mycophenolate, switch to azathioprine at least 3 months before pregnancy for the washout period. Okay. So maternal risk. Preeclampsia is the most common. Hypertension is seen. Blood pressure will be more than 50% of the baseline. GDM risk is also increased. It may be because of the patient, if the patient is on steroids or taking calcineurin inhibitors. The acute rejection risk is less. It is less than 2%. And VT risk is increased mainly in patients who are having proteinuria. The fetal risk is FGR, mainly because of placental insufficiency. Preterm birth, it may be spontaneous or iatrogenic. NICU admissions are common and perinatal mortality is increased. Now, what is the effect of pregnancy on graft? Graft survival is comparable. This we have discussed, so I'll skip this particular slide. So coming to the antenatal management, so renal function is to be monitored monthly. Tacrolimus and cyclosporine levels are required regular monitoring. Blood pressure is to be maintained less than 140/90, and urine protein is to be checked in each and every follow. Okay. So during the antenatal period, MSU midstream urine should be checked at booking, quantify proteinuria, GDM needs screening, and fetal growth scan will be done at 26 to 28 weeks and 32 to 34 weeks of gestation. Okay. So proteinuria is doubled in pregnancy. Further, there is an increase once you stop the AC inhibitors, and beta SH is falsely elevated. So false positive aneuploidy screening may be noted in these patients. So diagnosis of superimposed preeclampsia, how you will differentiate? Basically, uh, that is a dilemma. When you have a hypertension, proteinuria, there is a dilemma. But if there is a new proteinuria after 20 weeks of gestation, likely to be superimposed preeclampsia. Or if the blood pressure is more than 160 by 110, there is a doubling of the antihypertensive, or there is an increased proteinuria. Okay, that is 100% increase. And supportive investigations such as LFTs are raised. There is thrombocytopenia, there is FGR that will indicate more towards the preeclampsia. Okay. Then immunosuppressants in pregnancy, like tacrolimus, these levels of the tacrolimus are decreased during the pregnancy, so it requires monitoring. Cyclosporin, CYP 450 interactions, so erythromycin levels may be increased and may lead to the toxicity. Steroids, there is an increased risk of GDM. Biological agents cross the placenta, so avoid live vaccines in neonate. Okay. So intrapartum management. Mode of delivery, vaginal delivery is preferred. Induction with prostaglandins and oxytocin is safe. C-section, there is a risk of graft injury is very, very less, 1 to 2%. Incision, we can consider a midline incision in these patients, and fetal monitoring will be continuous, CTG will be required. Okay. By any chance, if the patient is on steroids and the patient is on prednisolone more than 7.5 milligram for more than 2 weeks, these patients will require IV hydrocortisone in the labor. Okay. Then PPH management, we need to avoid ergometrin while oxytocin and prostaglandins are safe. In the postpartum period, BP needs to be monitored and maintained below 140 by 90. AC inhibitors, enalapril is safe in breastfeeding. They will follow up with the transplant team, and contraception like progesterone only pills, Mirena, implants, these are safe contraceptives. Breastfeeding is safe with tacrolimus, cyclosporin, prednisolone, azathioprine. Important thing is that kidney donors, there is increased risk of gestational hypertension and preeclampsia. The risk is doubled. Consider aspirin prophylaxis for these patients. So take home message is that pregnancy is contraindicated within 1 year of transplant. Mycophenolate is to be stopped. It is teratogenic. Azathioprine is safe. Vaginal delivery is permitted. Then preeclampsia diagnosis is difficult and differentiation is difficult. Tacrolimus levels are decreased in pregnancy. Beta HCG falsely positive screening may be there, and proteinuria doubles normally. Patient requires multidisciplinary care. Okay. Now next is a pancreatic transplant. The key fact is that generally it is most of the patients may have combined transplant, kidney as well as pancreas transplant. Isolated pancreas transplant is rare. There is a decreased fertility versus renal transplant. It may be because of hormonal dysfunction. Maternal risk is increased. The complications in the renal transplant, there is an increased risk of preeclampsia, UTI, and renal graft obstruction. There is increased erythropoietin requirement also. Graft outcome, rejection chances are less, 0 to 6%. Highest risk of graft loss is within 1 year postpartum. Risk factors is an increase in creatinine and previous rejection episodes. So if there is a new insulin requirement, that will denote pancreatic graft dysfunction. GDM risk is similar to renal transplant patient. Okay, so management is same as a renal transplant patient, same type of medication changes and all. So monitor both grafts, watch for UTI and obstruction. Multidisciplinary team care is required, and our transplant surgeon involvement is to be done. Okay, so delivery high cesarean section rates, but it is not mandatory that this patient has to undergo cesarean section. Vaginal delivery is not contraindicated, and delivery in transplant center. Next transplant is a liver transplant. UK around 12 pregnancies per year undergo liver transplant and come across pregnancy. There is a risk which is more than the general population. However, the risk is less as compared to the renal transplant patients. Maternal and fetal risk will include there is increased risk of pre-eclampsia, preterm birth, low birth weight, and cesarean section. Graft outcome are the acute rejection chance is around 2 to 17%. Graft loss is around 10%. Impact of pregnancy is uncertain. So important from the examination point of view, alkaline phosphatase levels are increased physiologically. Okay. Then chronic renal disease plus liver transplant has got a worse outcome, and autoimmune hepatitis generally do not have worse outcome. So management, you need to monitor LFTs, tacrolimus, cyclosporin levels, renal function. Screen these patients for GDM and FGR. Okay. Delivery, vaginal delivery is not contraindicated. The next transplant is a cardiothoracic transplant, that is a heart and lung transplant. Key factors are it is very rare in pregnancies. Common indications are the congenital heart disease, cardiomyopathy, cystic fibrosis. The most important is genetic counseling, which is essential. Patient will require assessment by ECG, 2D echo, angiography, biopsy. The risk is similar to the renal transplant. Additionally, cardiac dysfunction, arrhythmia chances are increased, graft vasculopathy can be there, and lung transplant is the highest maternal risk. There is a decreased live birth rate and increased rejection rate. So in cardiac physiology, the denervated heart has got an increased heart rate and increased stroke volume, contractility. Then there is a increased sensitivity to catecholamines that leads to arrhythmias. Lung physiology is normal, increased tidal volume. FEV1 and FVC are unchanged. If it is decreased, that suggests there is infection or rejection. Management is intensive graft surveillance, low threshold for MDT escalation, and combined obstetric plus transplant care. Vaginal delivery is not contraindicated in these patients. So take home message that pancreatic transplant, if there is a new insulin requirement, then there is a possibility of graft failure. Highest graft loss is in the first year of the postpartum. Then liver transplant, the risk is less than the renal transplant. Alkaline phosphatase level are physiologically increased, so needs careful interpretation. Cardiothoracic lung transplant has got the highest risk group. FEV1, if it is reduced, that is a red flag, and all transplant require MDT care and vaginal delivery is permitted. Doctor, we have few questions. Can you please go ahead with the questions? Dr. Sinchana, can you read these questions?
Yes, sir. A pregnant woman with kidney pancreas transplant at 24 weeks develops increasing insulin requirement. What is the most likely explanation? A. Gestational diabetes. B. Steroid-induced hyperglycemia. C. Pancreas graft dysfunction. D. Physiological insulin resistance. E. Infection. So it is C. Pancreas graft dysfunction.
Correct. This is what we have discussed. If there is an increase in new insulin requirement, that will denote pancreatic graft dysfunction. So new insulin requirement in pancreatic transplant is a red flag or graft failure. GDM risk is not higher than the renal transplant alone. Next question.
Which of the following is true regarding pregnancy after pancreas transplant? A. Fertility is higher than renal transplant. B. Complication rates are lower than renal transplant. C. Vaginal delivery is contraindicated. D. Pregnancy is usually after combined kidney pancreas transplant. E. GDM is significantly increased. B. Complication rates are lower than renal transplant.
So the answer is D. Pregnancy is
D.
usually after combined kidney pancreatic transplant. Most cases will have combined kidney pancreatic transplant. Fertility is reduced and complications are increased as compared to the renal transplant. So these patients' pregnancy is usually after combined. Which of the following is true regarding
True.
pregnancy after pancreatic transplantation? This question is not very clear actually. Not very clear. I'm not very satisfied with this question. Okay, next.
Yes, sir. Following pancreas transplantation, when is the highest risk of graft loss in relation to pregnancy? A. First trimester. B. Second trimester. C. Third trimester, D. Immediately after delivery, or E. First year postpartum. First year postpartum.
Yes, it is first year postpartum. So peak rise of graft loss is within 1 year postpartum. Next.
Which of the following statement about liver transplant in pregnancy is correct? A. Risk is higher than the renal transplant. B. Pregnancy outcomes are better than general population. C. ALP is unreliable due to placental production. D. Vaginal delivery is contraindicated. E. GDM risk is negligible. It's, C, sir, ALP is unreliable.
ALP is unreliable due to placental production. ALP levels are physiologically increased, need isoenzyme differentiation, and risk is more
More
than the general
than
population, but less than the renal transplant. Next.
a woman with liver transplant is being monitored in pregnancy. Which parameter requires careful interpretation due to physiological changes? A. ALT, B. AST, C. Bilirubin, D. Alkaline phosphatase, and E. Albumin. D. Alkaline phosphatase.
Yes, alkaline phosphatase. Okay, so placental alkaline phosphatase increase may mimic liver dysfunction. Sorry. Yes, doctor. Question 6.
Which transplant group carries the highest maternal risk in pregnancy? A. Renal transplant, liver transplant, pancreas transplants, D. Heart transplant, or E. Lung transplant. E. Lung transplant.
It is a lung transplant, which is highest risk. There is a decreased live birth rate and increased graft rejection.
Yeah.
Next.
In a pregnant woman with lung transplant, a fall in FEV1 is noted. What is the most appropriate interpretation? A normal physiological change, increased lung compliance, suggests infection or rejection due to progesterone effect, indicates fetal compromise. It suggests infection or rejection.
Yeah, so FEV1 is the most important thing in these patients. Okay, FEV1 upon FVC normally unchanged in pregnancy. If it is decreased, it is pathological, suggests infection or rejection. Next.
Which of the following is true regarding cardiac transplant in pregnancy? A. Denervated heart cannot increase heart rate. B. Arrhythmias are uncommon. C. Increased sensitivity to catecholamines occurs. D. Vaginal delivery is contraindicated. E. Pregnancy has no effect on cardiac output. It is C. Increased sensitivity to catecholamines.
It is increased sensitivity to catecholamines because denervated heart, there is increase in a heart rate, stroke volume, contractility. There is increased sensitivity, which is responsible for arrhythmias. So take home message is that pancreatic transplant, if there is a new insulin requirement, it is likely to be associated with graft failure. Highest graft loss is seen in the postpartum period within 1 year. Liver transplant, ALP is misleading. Then lung transplant, highest maternal risk. FEV1 is decreased. It is not normal. Think of rejection or infection, and all transplants, vaginal deliveries allowed. So that is what is the take home message in this particular talk article.